Could you please present your findings and diagnosis, please?
So I believe this patient has mixed aortic valve disease. The clinical findings were that the patient was in sinus rhythm with no peripheral stigmata of cardiovascular disease. There was a slow rising pulse on palpation. On palpation of the precordium, there was a heaving apex beat that was non-displaced. And on auscultation of the chest, there was an ejection systolic murmur heard loudest at the left sternal edge and aortic region, which did radiate to the carotids. And there was also an early diastolic murmur heard again at the aortic region and at the left sternal edge.
What would you classify as the predominant lesion?
So I believe aortic stenosis to be the predominant lesion in this case, not because of the character of the murmur heard on auscultation, but because of the slow rising pulse and non-displacement of the apex beat.
So what other murmurs might you be able to hear with mixed aortic valve disease?
So the other main murmur that you could potentially hear with mixed aortic valve disease would be an Austin Flint murmur. This murmur is heard loudest at the lower left sternal edge and is caused by the regurgitant jet from coming through the aortic valve and hitting the anterior mitral valve leaflet.
Very good. What investigations would you like to do next?
So I would like to take a full history from the patient, particularly paying attention to their symptomatology. I would also like to do a full set of blood tests, and if there was any indication of possible infective endocarditis, I would do 3 sets of blood cultures. I would do an ECG, a chest x-ray, and I would refer this patient for an echocardiogram.
Could you tell me a little bit about the treatment of mixed aortic valve disease?
So the treatment of a mixed aortic valve disease, in this case predominantly aortic stenosis, is very much dependent on the patient's symptoms. If a patient is asymptomatic, they tend to be treated medically. For this, they are given beta blockers for rate control and generally given ACE inhibitors. If there's any signs of overload as well, they're given diuretics. In symptomatic patients, the treatment is generally via intervention, of which there are 2 types. One is TAVI, and the other would be a valve replacement via open heart surgery.
So TAVI is a form of percutaneous intervention. What's the benefits of doing that over, say, open heart surgery?
So open heart surgery remains the gold standard treatment, but TAVIs are generally reserved for patients who have greater comorbidities and a higher preoperative risk. This decision is made at a multidisciplinary team meeting and in conjunction with the preoperative assessments that patients have. That preoperative assessment will include generally a CT coronary angiogram, a full anaesthetic assessment by the anaesthetists, and in the elderly patients they tend to have a full geriatric assessment as well.
Thank you.
Thank you.